Welcome to our first tutorials on GMDC surgery. So this is basically for Ghanaian students who are writing their licensure exams. So we are here to help you prepare. If you are new over here, you might want to subscribe to this channel and of course, share it among your friends as well. And again, we own no right to the materials we are using over here. This is just for educational purposes. Educational purposes. So without wasting my time, let us start our questions. So we have a woman of 65 years old who sleeps getting out her bathtub, but manages to balance and prevent herself from falling. So the clue here is what? Is an old woman who is what? 65 years old who sleeps. And again, that means there was a problem with balance, isn't it? Good. And it occurred after falling. Now look at it. She soon, however, experiences pain in her right hip. There is pain and lying in bed. There was also what? Shortening of her left leg with external rotation at her hip. So please, these things I've underlined are the clues that are going to help you with your diagnosis. So first of all, we're talking about what? An elderly person who fell on the floor. And as a result, there is a problem in the hip. There is a problem in the hip. And one of the complications of such a problem is that there can be what? Shortening of the affected side. So the affected side can be shortened. So please take note of that. And by that, we are basically referring to what? A bone problem. We are referring to what? A bone problem. A bone problem. So let's look at the questions that we have. So we are going to look at the clinical diagnosis, the differential diagnosis, the investigation we need to do, the managing, and then of course, the possible what? Complications, which if they've already given you one of it, which is what? Shortening of the left leg. So, all right. So let's just zoom in into our diagnosis. So what are you thinking about? So for a diagnosis, we are looking at this as a fracture of the neck of the femur. Fracture of the neck of the femur. Look, when someone falls or when another person falls, the most vulnerable place to be fractured is the neck. Please take note. The most vulnerable place to be fractured is the neck of the femur. So that is why over here, the patient could feel some pains at that affected side. So please take note. So here we are looking at fracture of the neck of the femur. So let's look at our differential diagnosis. So with differential diagnosis, we can be talking about hemoarthrosis of the left hip, of course, the affected side. And hemoarthrosis simply refers to a condition that occurs as a result of bleeding into a joint cavity. Bleeding into a joint cavity. So when someone falls like that, there can be what? Bleeding into the cavity. And that can also lead to what? Pain at the affected what? Side. And that's why we said our differential could be what? Hemoarthrosis. Hemoarthrosis. We also have osteochondrosis. Osteochondrosis of the left femoral head. The word osteochondrosis, we are referring to a disorder that affects the growing skeleton. It affects the growing skeleton. So anything that affects it can lead to pain at the hip joint. It can lead to pain. Then we also have hematoma of the gluteal muscles. In other words, you can be thinking of this as a buttocks contusion. Buttocks contusion, yes. And one of the cause of a buttocks contusion is a fall or when someone falls. So over here too, we are going to see some bleeding within and around the gluteal muscles. Within and around the gluteal muscle. So we call it what? Hematoma. Hematoma of the gluteal muscle. That means bleeding into what? Tissues. Into tissues. Then we have what we call the extracapsular fracture. Extracapsular fracture. And this is a bone fracture near a joint, but still located outside the joint capsule. Hence the name extracapsular. That means it is outside the what? The capsule. Although the joint, the bone is near the joint. It is near, but it's what? Outside. An example of such thing is called intertrochanteric fracture or hip fracture, and then subtrochanteric hip fractures. These are some of the extracapsular fractures that you can be thinking about. So again, it's a joint or a bone. So it's a bone near a joint, but outside the capsule. Then, last but not least, we can talk about the pathological fractures or a pathological fracture where the bone is broken as a result of a disease. Bone is broken as a result of a disease rather than an injury. So when it's a disease being the pathogenesis of the fracture, we don't call it osteochondrosis or hematoma. We call it a pathological fracture. So therefore, we can add that one as our differential. We can add it as of course, there are a lot of things that we can talk about, but these are the few just for you to understand what we are referring to in this question. So out of this, just mention 3 of them and you're good to go. Now, the next thing is to talk about the investigation. Please, anytime there is a musculoskeletal damage or you want to verify something about musculoskeletal, that is the muscles and the bone, okay, please again, never forget to do your x-ray. Never, ever forget to do your x-ray. So one of our investigation, definitely we will do our x-ray of the pelvis or the femur because that is what we are looking for. So you do an x-ray, and of course, you can also do a full blood count to rule out any pathological fracture like an infection being present or whatever you might be thinking about. Then, of course, to ascertain the bleeding disorders and all those kind of things, check for platelet and all these things, they can all be found in the full blood count. And of course, you can do a CT scan of the hip joint, a CT scan of the hip. And again, you can do some electrolyte like the calcium, the phosphate, and then the phosphatase. You can do all of this. So these are all supporting tests to help you to exclude some diseases and then include some diseases. Basically, that is just it. So that is why over here, these are the investigations that you need to do as a doctor on duty. All right, so the next thing we'll be talking about will be the principal management. How will you manage such a patient, or how will you manage a fracture of the neck of a femur? So basically, we'll do pain management. Then we'll immobilize the person. Then we can do what? Surgery. So again, pain management, you can give your diclofenacs, your non-steroidal anti-inflammatory drugs and all those things. Immobilize the patient because the more you move, the more you're going to cause more problem. Okay. Then of course, you can do what? Surgery. If immobilizing the patient is not really helping, you can do what? Surgery. And under surgery, we can talk about the open reduction and internal fixation. So you open and you fix it internally. You can also do external fixators, or you can use external fixators and skin traction. Then you can do what? Hemoarthroplasty. That's more or less like a surgical procedure that involves replacing half of the hip joint. So you are replacing half of the hip joint. And then you can also have what? A total hip joint replacement. So these are the possible management that are available for such a patient. Now, the next thing is our complications. So what can arise when we fail to treat this person? What can arise when we fail to treat this person, or when treatment is ineffective or is inefficient? So basically, what happens is that there can be what? A non-union or a malunion. There can be shortening. Like I said earlier on, even in this question, they brought what? Shortening of her left leg. So there can be what? Shortening. There can be a vascular necrosis of the head of the femur, because of course, there are blood vessels that supply the head of the femur. So at the neck area, these blood vessels can be around it, and these blood vessels can actually what? Rupture, or they can be, problem can happen over there, and there will be inadequate supply of blood to those tissues around the head of the femur. So that can lead to what? Necrosis. Then we can have what? A delayed union, deep vein thrombosis, urinary tract infection, pneumonia. We can have, fecal impaction, and then incontinence. So, yeah, all these things can happen in this patient. So please take note. And all of these things, you have to just to mention, I think, just three complications. So you can talk about malunion, non-union, shortening. These three alone can even help you with everything. And please, so put these things in your head that anytime there is a fracture, and trust me, there will always be a question on fracture. I won't say always, but the probability that there will be a question on fracture is always what? High, almost in every year. Although in October, there were no much question on fracture. But hey, don't miss it. If a fracture comes, please just kill it once and for all. So that is that for this question. We have a 60-year-old man who had difficulty with micturition marked by poor stream, dribbling, hesitancy, and occasional hematuria. Look at the age again, 60 years old man. Examination reveals a healthy-looking man with a normal penile shaft and an enlarged elastic prostate showing medium and lateral grooves. So again, what are your clues here in diagnosis? The old age of the man, and of course, the micturition problems like the dribbling, the hesitancy, the hematuria. These are not good signs. And of course, for the fact that there's what? An enlarged elastic prostate. There is an enlarged elastic prostate. And here the question says what? We should give what? Differentials. Yes. Differentials, management, complications, and diagnosis. And the investigations to do. So let's start with our possible differential diagnosis. We can be talking about what? A cancer of the prostate. We can be talking about the BPH, or a benign prostatic hypertrophy, or benign prostate hyperplasia. People can put it that way. We can talk about what? Chronic prostatitis, then a prostatic abscess, then a prostatic calculi. Prostatic calculi is what? The presence of a stone in the prostate. Yes, it's possible. It can also be an abscess or an inflammation. So all of these things are our differential diagnosis. All these are our differential diagnosis, and it's only by a lab or a biopsy that possibly can tell us what is really wrong with this patient. Okay, so again, these are your possible differential diagnosis. And what are our modalities for management, or how will you manage this patient? So first of all, you can do what? A watchful waiting, or a conservative treatment by just observing how things unfold. Then you can do a medical therapy. Then, of course, you can remove the prostate if you are thinking of a problem with the prostate, let's say a carcinoma or something, you can remove it. Then you can do what we call the transurethral recession of the prostate, then a radiotherapy. These are the modalities for management. And of course, if the patient is having difficulty to urinate or something, or the bladder is kind of full and the person cannot urinate, you can also pass a catheter. You can pass a catheter to drain everything, to drain the fluid. That's when there's an acute urinary retention, okay, as a result of a carcinoma of the prostate. You can do all of these things to help you relieve the patient, or for the patient to be relieved. Okay, so let's look at the possible complications arising from operative management. So what do we have? So complications, what do we have? We can talk about UTIs or urinary tract infections. We can talk about sepsis or wound infections. We can talk about incontinence of urine. We can talk about injuries to the ureter's stricture or urethral stricture. We can talk about infertility or sexual dysfunction. All of these things can be mentioned as a complication resulting from operative management. So please remember these. So what are our diagnostic tests, or what tests will you do to confirm your diagnosis? So here we can talk about the PSA. We can talk about the ultrasound or abdominopelvic ultrasound. We can do a transrectal ultrasonography, and of course, our prostatic biopsy, or a prostate biopsy especially, and this will help you to rule out the presence of a cancer. It will help you to rule out or rule in the presence of a cancer. So these are the basic tests that you need to do. All right. So that is that for that question. And then now we move to the next. We are having a 45-year-old man who is seen in the medical surgical emergency complaining of colicky abdominal pains of 36 hours duration. That's almost 2 days. So 1.5 days. And there's absolute constipation. So inability to pass stool. He had vomited repeatedly, and on examination, he was moderately dehydrated with abdominal distension. Look, I'll tell you a story. I won't say a story per se, but I have looked at a patient like this, or I've attended to a patient like this before, whereby the patient cannot pass stool. Unfortunately, I was at the clinic. Clinic, we don't have so many things to do. So I referred this patient to one of the hospitals. And after I referred the patient, I think it was a night. So after I referred to the patient, and it was on a weekend too. And there was a problem in the sense that, weekends, we don't do labs, or we don't run ultrasound and all those kind of things. We don't do that. I mean, in Ghana, to be specific, we don't do some of these things because they're either on holidays or they are enjoying their weekends. So the person was to wait until Monday. But unfortunately, this person passed out. Like, he's gone. Just like that. So please, things like these, don't take it lightly. Very, very, very crucial. And it is very, very, very common in our setting. So please understand these things. So absolute constipation, there's abdominal distension, tenderness, and guarding over the lower midline incisional scar in the abdomen. And look at it, there's also what? Dehydration. So please, colicky abdominal pains, absolute constipation, dehydration, abdominal distension, tenderness. Please, these things, never forget them. And when you see these things, please and please again, you're definitely thinking of what? A problem with obstruction or intestinal what? Obstruction. That is what comes to mind because you're not able to pass stool. So something is obstructing the stool from going out. Something is obstructing or something is blocking it. So please take note of that. So in our question, they say what? We should indicate the precise diagnosis, including what? Antecedent. That's more or less like accompanied complications. Then differentials, then management, then complicate, then investigation. So let's go through them one after the other. So what are your possible diagnosis, or what is your possible diagnosis? And again, like I said earlier on, we are thinking of what? An intestinal what? Obstruction. Intestinal obstruction. Intestinal obstruction. Of course, they didn't give us any further history to tell us whether it was as a result of adhesion or there was an operation on this person before that or not. They didn't tell us. They didn't tell us. So you cannot just put it secondary to adhesion or something like that. Yes, it could be. It could be, but no information or not much information was given to be saying it's secondary to something. So just to be on the safer side, just write intestinal obstruction, although I stand to be corrected. But basically, we are dealing with what? Intestinal obstruction over here. So if you're not sure, just write your intestinal obstructions and you are free. And what are the accompanying complications that might arise or that may be present? There can be shock, because they said there's dehydration. So this moderate dehydration could be severe and it can lead to what? It can lead to shock. And with shock, we can be dealing with what? Hypovolemic what? Shock due to what? Severe dehydration. There can be hypovolemic shock due to severe dehydration. Of course, since the person is able to pass through and there's abdominal distension and all that, they can also lead to what? Endotoxic what? Shock. There can be electrolyte imbalance. There can be renal failure. There can be peritonitis and perforation. These are very, very, very common. Perforation and peritonitis, they are very, very, very common. And as a matter of fact, when people are having peritonitis and perforation, there's a general abdominal tenderness. Tenderness will be present. Tenderness will be present. So please take note of these things. And of course, there can be multiple organ failures. Multiple organ failures. So any of these things can help you with your diagnosis or the antecedent what? Complications. All right, so let's move to the differential diagnosis. So what are our differentials? So we can be looking at for what? For peritonitis. Like I said earlier on, when somebody is having peritonitis or perforation, you could also be thinking about what? Tenderness or generalized abdominal what? Tenderness or guarding. All of these things can be what? Can be present. They can be present, can be what? Abdominal distension. So these things are possible. So again, differentials, and like I said, typhoid fever, and as a result, it can lead to what? Typhoid perforation. Typhoid perforation. So one of the complications of not treating typhoid fever is that you can have what? A perforation. Then you can have a paralytic what? Ileus, obstruction of the large intestine. We can talk about acute appendicitis, severe constipation. So these are our possible differential diagnosis. So any two of these will make your day or will give you all the needed marks. Of course, you can add as many as you want to, but these are our findings. So please enjoy it and let's move on. Now let's go about the principal management. How are we going to manage such a patient? How are you going to manage such a patient? Don't forget, this person is in pains. Is in pain. So think about it. This person cannot pass through. Cannot pass through. Okay? So there's what? Absolute constipation. Cannot pass through. And as a result, there's what? Abdominal what? Distension and all those things. Tenderness is present. So please, how are you going to manage this patient? So basically, we have to give what? Some pain medications or analgesia to reduce the pain. You have to do an NG tube drainage. That means removing content from the stomach through an NG tube or through a nasogastric tube. So you pass a tube from the nose through your mouth into your stomach. That's what we call the NG tube drainage. So then you draw everything. Then we have what? Nail by mouth. That means nothing should pass through the mouth. Don't give feeding. Don't say, let me feed the person. The person is hungry. Let me feed the person. No. Don't give it by mouth. Don't give it by mouth. Then, of course, you can do what? A catheter what? Drainage. You can do a catheter drainage and you monitor the urine what? Output. You monitor urine output. You can give antibiotics. Of course, you should give antibiotics. Then you can give what? Your IV fluids. IV fluid to compensate for the what? For the dehydration. IV fluid to compensate for what? The dehydration. So these things will be our principal management. They will be our principal management. So basically mention them. Sometimes too, on the question, the paper or the sheet, the space between it is very small. It's very small. I tell people, see, write, even if you have to squeeze them, write them and squeeze them there. You don't want to miss anything out. Please write them down. All right. So what are we looking at? The complications. And you see, the immediate complication or the attendant complications or the accompanying complications, most of them, they are just the same thing. Or they move hand in hand. Let me put it that way. So basically, you can talk about the same things, and I've added some few things, or we have added some few things. So you can talk about the fluid overload. You can talk about sepsis, ischemic necrosis, perforations, strangulation, adhesion. Usually when they do surgery, there will be what? Adhesion. Adhesion can develop. And again, we can talk about what? Peritonitis, paralytic ileus, then an abscess or intra-abdominal abscess, then enterocutaneous fistula. Enterocutaneous fistula. So these will be our possible what? Complications. So any 4, you are good to go. Any 4, you are good to go. So investigations. So basically you do what? An abdominal x-ray. Abdominal x-ray. This can be erect and supine. So abdominal x-ray, then you do chest x-ray. Now, why you have to also do a chest x-ray is it can also help you to locate a perforated problem or a perforation. Usually you will see it on the hemidiaphragm on the right side of the x-ray or the right side of the lungs. You can see some perforations there just under the diaphragm. Some perforation can be there. So you can do the chest x-ray to also confirm or rule out any perforation. Then, of course, you can do a supporting test, that's like the full blood count, to know if there's an infection or anemia or anything. It will help you. So these are the investigations that you are going to do. So data that they didn't mention the specific number of investigations, please just mention all of these and you are good to go. All right, so here, that is it for this patient. That is it for this patient. All right, so let's move on. We have an 8-year-old boy who is brought to the casualty complaining of a severe pain around the right elbow following a fall on the outstretched hand. Please, outstretched hand is a very, very good indicator for a particular diagnosis. Now, tenderness and crepitus are elicited in the elbow region. So you see, so these things, like I said earlier on, falling on an outstretched hand is a clue for two main things, two main diagnoses, at least for now. So anytime that you are seeing an outstretched hand, you can think of Colles fracture or Colles fracture. That is Colles, Colles fracture. That will be on the wrist. They tell you that there's a problem with the wrist and the person fell on the outstretched hand, that can come to mind. You can think of what? A Colles what? Fracture. If not, you can be thinking of what? For the supracondylar fracture. That is a fracture just above the elbow. A structure just above the elbow. So these are the two what? differentials that you can be what, or you should also be looking at for. Should be looking at for. So depending on what they say it is, okay, depending on what they say it is. But over here, we are saying that there is tenderness and crepitus at the elbow region. So that means that this will rule out a problem with the risk, isn't it? So there's no problem with the risk. So Colles fracture is totally out of place. So let's move on to our clinical diagnosis over here. So of course, we are thinking of what supracondylar fracture of the humerus, a supracondylar fracture of the humerus. And again, how are you going to treat this injury? So treatment. So by treatment, you can do what we call for undisplaced fracture. Undisplaced fracture, it requires an above elbow plaster for 3 weeks for undisplaced fracture. Then when fragments are displaced, you can do a manipulative reduction under general anesthesia. A manipulative reduction. Then we can also do a reduction by traction and manipulation with POP external back slap. And of course, careful monitoring of the radial pulse. Then we can also look at for what? In case of an open, or we can do an open reduction and internal fixation. So we open and fix it what? Internally. If close reduction fails us. So if doing a close reduction, it is not helping us, you can do an open reduction and then do internal fixation. Do internal fixation. So these are by far the possible treatment available for a supracondylar fracture of the humerus. And again, it will depend. It depends on what will happen, whether it was a displacement or no displacement. Okay. And again, we're looking at what the complications of supracondylar fracture. Complications of supracondylar fracture. Again, you can think of a fracture, just any fracture. When we mention about the malunion, all those can all be part of the complications. But for this reason, can also add more, or we can add more to it. So we can talk about vascular injury, that's vessel. We can talk about the nerve injury. We can talk about compartment syndrome. And a compartment syndrome simply refers to a painful condition that occurs when pressure within the muscles builds to a dangerous level. So when pressure within the muscles builds up, that can lead to what? A compartment syndrome. And this pressure can actually decrease blood flow and, of course, prevent nourishment and oxygen from reaching nerves and muscle cells. So some of the symptoms or the signs and symptoms of a compartment syndrome may include pain. Actually, they refer to it as the 5 Ps. 5P. So 5 Ps. So you can think of pain. You can think of pallor. You can think of paresthesia or numbness feeling. You can think of pulselessness or a faint pulse, pulselessness. Then you can think of paralysis. So these are the 5 Ps of compartment syndrome, and all these can be a complication of a supracondylar fracture. Then again, you can think of what? Malunion. You can think of a delayed union. You can think of non-union. All of these things, you can be thinking about them. Anytime you are seeing a fracture on the bone, think of some of these things. Even if you have nothing to say, think of these things. Okay. Then, of course, we can also talk about stiffness. So, what are our differentials? So, differential diagnosis of a supracondylar fracture is there can be a dislocation of the elbow, or this can be a dislocation of the elbow. This can be a fracture of the capitulum. We can talk about intercondylar fracture. Intercondylar fracture. So these are the possible differential diagnoses that you can look at for in a person suffering from supracondylar what? Fracture. Then what are our investigations? So basically, you need to do what? An X-ray. Like I said earlier on, if there's a problem with musculoskeletal, what do? You do what? An X-ray of the side or the affected what? Side. So X-ray of the elbow in flexion and in what? In extension state. So basically, these are the explanation we can give to this wonderful question. So let's move on to the next question. Great. Now, before I continue with this topic, I would like to draw your attention to the fact that all these questions and information that we are giving out, you can find them on the Meden app. At the moment, it's available on Play Store. It's available on Play Store. So please do well to download the app, and more of these will be there for you. More of these will be there for you. Okay. Now we have a 35-year-old man who presents with a severe pains in their buttocks with fever and rigors of 3 days duration. Look at it all. 35 years old, there's pain in the buttocks with fever and rigor. So definitely an infection is present, right? Now on examination, he is vaguely tender to the right of the anus, and rectal examination, though uncomfortable. That means this person was not what? Comfortable. So it was uncomfortable with no particularly what? Tender. So this is what? An infection that is occurring at the anus. At the anus. So what are you thinking about? Definitely an infection in the anus. In the anus. And this, we can refer it to what? As a anorectal abscess. Anorectal abscess. That means an abscess in the anus and, of course, the rectum. So that place can be what? An infection over there. And that is why we are having in this patient, or that's what we are seeing in this patient. So let's look at it in detail. So what are your diagnoses? So this is what? Anorectal what? Abscess. Anorectal what? Abscess. And in anorectal abscess, there's always a collection of what? Of a pus near the anus. Near the anus. And you know, pus formation is simply signifying what? An infection. Simply signifying what? An infection. So what are your diagnosis? What are our diagnoses? So for our diagnosis, we can talk about a severe anal or perianal with pains. We can talk about swelling, induration, or redness. We can talk about what? High temperature. Sorry, these are diagnostic features, not differential diagnosis. These are what? Diagnostic what? Features. So we're looking at what? Perianal pain, swellings, induration and redness, high temperature. We're talking about diarrhea. So there can be diarrhea or even constipation. And there can be what? Lower abdominal pains. And there can be what? Rigors as well. So these are our diagnostic features. Our diagnostic features, or what to look out for to be able to confirm that, yes, this person could be having anorectal what? Abscess. Anorectal abscess. So again, let's look at the complications present in this patient. So what are the possible complications? Possible complications may include perianal fistula. We can talk about cellulitis, DVT or deep vein thrombosis. We can talk about sepsis. We can talk about what? Hemorrhage. So these are our possible complications of anorectal what? Abscess. I will encourage you guys that all the diagnosis that we have mentioned in this presentation, please, if I were you, I would take my time and go through them again, read on them. And most of you are doing classes and stuff. These are going to help you to add up to the knowledge you already have. So now go back to the tutorials you did, wherever that you were or wherever you did it, and get the topic that we have highlighted here, because these are high yield questions. Please don't let me talk too much, but basically that is that is that. All right. So thank you. And I hope you enjoyed it. And please do well to inform your friends, share, subscribe, and let's have fun. And please feel free to ask your question in the comment section. So for now, I'll say goodbye.